Hello, hello, hello. Thank you so much for joining us for Ask Miss Jai Live. I am so excited for our conversation today. We're going to have an opportunity to learn more about MPOX, to learn about the vaccine, to learn about ways that we can care for our health. And so I'm really thrilled to be here and to be sharing this information and introducing our guest here in just a moment as well. If you are checking this out live, please put a hashtag live in the comments. If you're catching it on the replay, go ahead and put a hashtag replay. You can ask any questions that you have in the comments as well, and we'll be able to get back to those, give you answers and get you information after this post live. So we're really excited. I want to welcome Dr. Kevin Carmichael from the Arizona Department of Health Services and Southwest Interdisciplinary Research Center at the Arizona State University. Thank you so much it's such a mouthful.
Yeah, for sure.
Thank you so much for joining me and joining us to have this conversation. I'm going to just share a little bit more about you, and then we can jump into some of these pieces. So Dr. Carmichael is a family physician who began work in HIV in 1983 while in medical school in Miami, Florida. While in residency, he co-authored one of the first handbooks for clinical HIV care, the HIV/AIDS, a primary care handbook. He completed a fellowship in academic family medicine at the University of Arizona in Tucson in 1990, and then moved to the El Rio Community Health Center, where you founded the El Rio Special Immunology Associates, a Ryan White-funded HIV clinic, where you served as medical director and provided direct patient care until December of 2018. He has long been active in HIV advocacy locally and nationally. He was a founding board member of both the HIV Medicine Association and the Ryan White Medical Providers Coalition. He served 2 terms on the panel on antiretroviral guidelines for adults and adolescents, and currently works as an academic detailer for the Arizona State University Southwest Interdisciplinary Research Center in partnership with the Arizona Department of Health Services. And additional interests include HIV workforce, innovative and effective models of HIV care delivery, health equity, end-of-life care, and competitive cycling. My goodness. You have done so much and so much for our community. This is amazing. So many of these pieces I didn't even know that you had done as well. And Dr. Carmichael and I have worked in community for quite some time together. So I'm really excited that you're here and to be able to have this conversation. Thank you for being here.
My pleasure. I'm actually really excited to be here.
Well, to start us off, could you share a bit about, we just read your bio, but could you share a bit about your medical background and what brought you to work on MPOX?
Well, everything really started for me when I started medical school. It was in the early 1980s when HIV was happening, but still unknown. And, it was exciting as a new infectious disease. It was exciting becoming a doctor in that time. It was also terrifying because most of my friends actually died from HIV over the next decade. So it resonated with my interest in taking care of underserved people and taking care of people that other people didn't care about. And so I don't think I started off to be an HIV doc, but that's what I ended up doing. And it was a good thing to be. It actually was really nice. Actually, the best time in HIV, it was a horrible time, but it was the best time as a doctor because in the early days, because everybody was terrified of it. So they were happy to leave me alone and let me do it. And in medicine these days, if you can be left alone and do your job and not be bothered by administrators and all, it's actually a nice thing. So again, it was hard, but I've learned a lot living through all that, through that experience. And so interestingly, when MPOX came along, in some ways it was like, deja vu all over again. This new thing was happening. How was the community going to respond? Being an old guy and very impatient, I was like, we got to do something now. We have to act. And I think you and I worked together on that early. A little over a year ago, we did a question and answer for the community through the Pima County Health Department. So that's why I ended up there. And it's just all sort of part of the same continuum of trying to take care of people where they are, what they need, and explain things. Because the interesting thing about MPOX is that it's not brand new, but it's pretty new, and what we know has changed a lot even in the past year.
Yeah. I appreciate you likening it to not a lot is known, and not a lot was known in the early years of the HIV epidemic as well, because many people in our community haven't heard much about MPOX or might have misconceptions around what MPOX mean, or only heard about it in the context of it affecting men who have sex with men. So can you tell us a little bit more about MPOX? What are some of the symptoms and what folks can look for?
Well, fundamentally, MPOX is a virus. It's a virus in the orthopox family. So the orthopox family is a big family of virus. There's a bunch of things that you've not heard of, cowpox. There's something I'd never heard of until recently called Alaska pox. But the one that you have heard of is smallpox, and smallpox is sort of the big bad virus in that family. And much of what we know about MPOX really is about much of what we know and much of what we do about MPOX really comes from what we had prepared for and what we did with smallpox. So MPOX is a virus. It's transmitted. First of all, it used to be called monkeypox. Why was it called monkeypox? Not because it's carried by monkeys or something, because it was first identified in a colony of monkeys in Denmark that were being kept for research. That's where it was first found, and hence the name monkeypox. But the truth is, it's probably its reservoir where it lives natively is in small rodents in Africa. And so up until up until last year, most MPOX was seen in African countries in young people and children who were being exposed to rodents through catching them, through hunting, through being in a place where rodents were. But of course, the other problem with MPOX is it started in Africa, which is pretty medically neglected. And so actually in Nigeria in 2017, there was evidence that something had changed and it was becoming a sexually transmitted infection. But again, that evidence wasn't widely known because, again, it was Africa, and we don't pay as much attention to Africa as we should. So at any rate, it's a viral infection. It's transmitted generally by personal contact, close personal contact. And the result is people can get sick. And when we say sick, that's a viral syndrome. So it's fever, muscle aches, joint pains, feeling bad. And then people get a rash. And classically, that's how it presented. But in the 2022 outbreak, we started seeing people getting the rash before they got sick. So you get the rash and then you start to feel fever and other things. Some people don't get fever or things. Some people just get the rash. So it's kind of the symptoms are very widespread. Rash is generally the most common thing, but other things can occur. Again, the malaise and things like that, but it can actually cause quite severe disease and can cause death, although doesn't kill a lot of people, but it can kill people. We can talk about that a little more too.
Yeah, when you say rash, are you talking about like a rash that might be in one area or like a full body rash?
Well, that's quite variable. Okay. So most in the current app, and I think I'm going to talk, there's a lot of stuff that happened before, but I kind of want to let that go. There was an outbreak in the US in 2003 that was associated with giant Gambian pouched rats that were brought to the United States to be sold as pets. It got into some prairie dogs that were next to them, and then the prairie dogs infected people. But let's really talk about 2022 onward. And what happened is the virus got into a community of people that were having sex, and it became really essentially a sexually transmitted infection. And so when you talk about sex, it's like, what kind of sex? Well, every kind of sex that you can have. But we see the rash a lot of times presents in areas where you have sex. So in your front, in your back, basically, but you can get it in your mouth, you can get it anywhere on your skin. And so the presentation can be quite varied. It can be just a single lesion, 2 lesions. It can be lesions all over. The problematic lesions are if you get them in your butt, if you get them in your penis, if you get them in your mouth, if you get it in your eyes, because those are all places where you really don't want to have a lot of inflammation and pain and things associated with it. In your eye, it could lead to blindness even. In your mouth, obviously, it's very uncomfortable, difficult to eat or drink or swallow. In your urethra, you can get swelling, get to the point where you can't urinate. And in your butt, it's really painful. You can have bleeding. You can get, it hurts so much you can't poop. Lots of bad things can happen. On your skin, you can get some pretty big lesions. But again, the important thing to recall as we talk about MPOX is in most people, it is a self-limited illness. It goes away by itself over a week or two and isn't necessarily that severe. Of course, we always say things aren't severe, and it's not severe to me if you have it, but if you have it, it's pretty severe to you.
Yeah.
The other thing is that people with immune compromise do worse. And so it's actually can be problematic in people with some autoimmune conditions, with some skin conditions, and of course HIV. And most of the deaths that we've seen have been in people with HIV. In general, people who had HIV, may not even known, weren't on treatment, were profoundly immune compromised. That's where people got the sickest.
Okay. And I heard you mention a number of body parts. My assumption would be that folks with vulvas, vaginas, that lesions in those areas would also be incredibly painful, would also similar to the other body parts that you mentioned as well.
Correct. I think most things, if you think about it like a burn, if you have a burn on your arm, that's uncomfortable, and you can kind of cope with that. But if you have it in your mouth, in your vagina, in your butt, in those mucosal areas, it's a lot more painful.
Yeah,
So,
absolutely.
So, and that's really the bottom line is the viral infection injures the mucosa, injures the skin. And so it's uncomfortable.
So let's talk a little bit about transmission, because I heard you say sexually transmitted. I've also heard you say skin to skin or close contact. And so I think what we're seeing right now a lot of in our community is the assumption that MPOX is only sexually transmitted. And so can you share a little bit with us around what transmission looks like and when folks should be concerned about transmission?
Yeah, so that's, so early on, there was still a lot of unanswered questions. And the bottom line is that it can be transmitted. You hearing that? Was that you?
I think that was me. Sorry.
Okay. But it can be transmitted by skin-to-skin contact. So if someone has a lesion, MPOX lesion on their hand, there's a ton of virus there. And if you rub against that, in the course of having sex or in the course of whatever, there could be transmission. And it can be transmitted to any mammals. There was a case well documented in France of a couple who both had MPOX, and their dog slept in the bed with them, and the dog got MPOX. So it can be transmitted. There was concern because it can be found on surfaces and stuff, that there would be lots of sort of casual transmission in households and things like that, but that has not been borne out. The three areas where we think that that transmission can occur from is from skin, from the mouth and saliva, and from the anorectum. Now, virus has been found in semen and urine and conjunctival fluid, the fluid, tears basically, in blood, feces, in the vagina, but there's not, in some of those places, they've even found replication competent virus, so live virus, but really only those three places, skin, the mouth and saliva, and the anorectum, have really been associated with transmission. So there have been cases of transmission through needle sticks. There was healthcare workers who were using a needle to unroof one of the lesions to get a test specimen, which is not necessary. But at the beginning, people didn't necessarily understand that, and then got stuck, and they got MPOX through that. There have been a couple cases associated with tattoo parlors. And there have been some cases of household transmission. There was somebody who had MPOX, who had a baby, and was holding the baby a lot, and the baby got MPOX. So it can be transmitted more casually if, holding something is casual. But again, it generally requires pretty close skin-to-skin contact. And of course, where most of us have the most close skin-to-skin contact is during sex.
Yeah, close intimacy, connecting with our bodies. Absolutely.
Yeah, exactly. So that's No, go
Sorry.
ahead. I'm sorry. No. I was agreeing with you. Yeah.
One of the questions that has come up for me in transmission, and you mentioned saliva as well, is concerns around respiratory droplets or like if breathing could lead to MPOX exposure. Can you speak
Yeah,
to that at all?
yeah, early on there was concern for that, and it's in some of part of the thing is, again, we're learning as we go along, and the only way we know anything is because it's already happened. Okay, so there was concern initially about that, but it seems um, pretty pretty uncommon, pretty unlikely. It's not, it's not of a huge concern. It's certainly, I wouldn't go so far as to say it's impossible, but it's pretty unlikely.
So that difference between like a theoretical concern versus something we've actually seen take place.
Right.
Okay.
Exactly.
Can transmission occur once symptoms are gone?
Well, let's talk about transmission, because the thing that we have understood more recently is that before someone becomes symptomatic, so before they have a rash, before they have a fever, it seems that people can transmit to other people before they get symptoms, up to maybe 4 days, 5 days before symptoms begin. So I could be feeling fine, you could be feeling fine, we could decide to have sex, and I could give you MPOX because I had it already, but I didn't know. Now, you asked about after the fact, and it seems, so we consider people to be infectious until all their skin lesions have healed. And that can take up to 14 days. Some countries, not the US, have recommended that people use condoms for up to 8 weeks after they recover from infection, because of this concern that it's found in semen. But so that, again, it's sort of, we always want to err on the side of caution. But I think once people's skin lesions have healed and they're clinically better, they don't have fever, they're not having ongoing symptoms, they're probably not terribly infectious. And the issue of using condoms for 8 weeks, it's out there in some of the other countries' guidelines. It's not in the US guidelines. But the issue of pre-symptomatic transmission, I think, is what drives this epidemic. One of the things I know I'm going to say this probably more than once, is I think we have an obligation to protect each other. So if I have a rash, I'm not going to have sex with anybody till I know what my rash is. If I'm feeling sick, I'm not going to have I'm not going to put other people at risk till I know what's going on. So I think that's important. I think we all owe that to each other as part of as part of being human, as part of being in a society. But that pre-symptomatic transmission definitely can be something that is driving outbreaks.
Yeah,
Because
and I
again,
think I think a lot of us have that same drive, have that same like we want to make sure that we're caring for our community. And in fact, a lot of the folks that I've talked to from the trans and non-binary community around MPOX has said like we care about each other, because oftentimes we're the only ones who have cared about each other. And
correct.
so I think it's more so understanding what this actually looks like, because we've received a lot of misinformation, or that we're not at risk, or that we are at risk, or that we're the only ones at risk. And so I think it becomes more so better understanding what this means so we can make more informed decisions around how we engage with one another, and when we should like cool our jets for a little bit as well.
Yeah, well, absolutely. And part of that is the whole, I want to say human nature, but I don't know if that's really true. But this idea of blaming people for things, it's like, we want to blame somebody for everything. It's always somebody, and somebody we don't, we disapprove of in some way. And I think it's just, I can't say the word I really want to use, but I think it's a crock. So, in my experience with HIV, with everything, nobody I don't know anybody who's wanted to give with HIV, who's wanted to give HIV to somebody else.
Mm-hmm.
And the same thing with everything, but you don't always know.
Yeah. And we won't get too in the weeds around blame and the way blame and stigma have shown up in this as well, because it's similar to what we saw with HIV and the HIV epidemic, and the pathologizing of communities, or saying like, this is the only community that's at risk. This is the only community that's experiencing this. I think that has been a big motivator for misinformation around MPOX.
Yeah, I think, that's we could do a week long discussion of all.
Yeah.
of all
Yeah.
that stuff, and then I'd have to use words that I don't want to use. But
Yeah. Well, so what are some of, so we've talked about like the acute, like what happens in the immediate, what we've seen. What are some of the long-term effects of having had MPOX?
fortunately, most people recover just fine without any treatment at all. So obviously, not obviously, the big concern is if you have severe injury to the mucosa of the mouth or throat, you could have scarring and strictures, scarring that makes it difficult to swallow or something. But that's relatively uncommon. The same thing in the butt, in the vagina, inside the penis. You could have some scarring that results in obstruction or something, but and same on the skin, you can get some scarring. But beyond that, most people who recover seem to do very well.
Can that scarring, especially in sensitive tissues, can that lead to a decrease in sensitivity, or issues with like sexual pleasure?
I would, it would not surprise me. I can't say that I've heard of that specifically. And again, I think that that has been a big concern, but we really haven't seen that much follow up on people. At least I haven't read too much about follow up on people with severe disease like that. Again, the majority of people, it's sort of those two camps. The people with untreated HIV, profound immune suppression, can do terribly, but most everybody else does pretty well, which is a good thing.
So, what are some ways that that if someone does contract MPOX, what are some ways that it can be treated, and what can we do to prevent MPOX?
Okay, so the first thing is prevention is, again, part of it is taking care of others. So, hopefully, talk to people, especially when there's outbreaks. We've been very fortunate. Last year in August, it was terrifying. The curve of the epidemic of the outbreak was skyrocketing. It went away. We could talk about a little about why it went away, and we've all been anxious that it's going to come back. But it's August and it hasn't come back yet, so I'm feeling a little bit better about that. And when I say it hasn't come back, there was an outbreak in Chicago in May, about 40, 45, 50 people total. But we haven't seen these big outbreaks. But there's nothing that's preventing that from happening in the big picture. And right now, I read something just today from the WHO that currently Mexico is is the country with the most increase in cases. But again, it's not skyrocketing like it did initially. As far as prevention, so one is, avoid anybody that's got a bad rash until they know what it is. Vaccination is important in prevention in two ways. If you're exposed to someone who has MPOX and you get vaccinated within a week of that exposure, it can prevent or greatly decrease the severity of resultant disease. So vaccination is probably the biggest prevention thing out there. Lot to say about vaccination, but just to go real quickly into treatment, there is a drug available to treat MPOX, but to be very honest, we don't know how good it is because it was a drug that was developed to treat smallpox, and you can't do human trials of smallpox because smallpox has been eliminated from the world. It's only found in laboratories and in military facilities because it's considered a bioweapon. Okay, in other countries, hopefully, and not the United States, but I don't know for sure. But anyway, so there's animal studies, and so we've been using TPOXX, and the anecdotal reports you hear is people get better when they're on it, but you also have a disease that most people are going to get better from no matter what. So it's a little hard to know. And so we were referring people to the trial, but the trial has not accrued a lot of people and we don't have any data yet. But this drug is well tolerated. It seems very safe. Unfortunately, it does have a low threshold to the development of resistance. And there have been cases of MPOX becoming resistant to that drug. People that have had generally immune suppressed people who've had MPOX for a very long time have had multiple courses of treatment. Their virus can become resistant to drugs, just like we see in any viral illness. HIV is the one we have the most experience with. So that's a drug that's available. And but again, most people don't need it because they're going to get better without any treatment.
Mm-hmm.
Of course, if people have bad symptoms, you might treat pain or other symptoms that come along. They can get the lesions on the skin might get infected by bacteria. There's other things that can have other complications, but that's a direct thing. As far as the vaccine is concerned, again, the vaccine was developed primarily for smallpox. So in this country, we have 2 smallpox vaccines. We have millions of doses that are stored by the government in case there's a bioterrorism smallpox. There's one vaccine called ACAM 2000. It's an attenuated virus, so it's a live virus, but it's not very powerful, but it can cause systemic disease. So we don't recommend that for vaccination against MPOX. There have been people who were, for instance, in the military, they get that vaccine because they're soldiers and they may be exposed to smallpox if there's bioterrorism or bio warfare. And there's some evidence that people that had that smallpox vaccination in the past are less likely to actually get MPOX. The vaccine that we're using for MPOX is called Jynneos, and it is a replication incompetent virus. So it's a virus, but it can't reproduce. And so you get that vaccine, your body sees that virus, it develops an antibody response that is protective over the long haul. The course of Jynneos vaccine is 2 doses, 1 today and 1 in roughly a month. We saw a lot of people get their first dose back in August of 2022 when everyone was really scared of how big this was getting. A lot of people never followed up with their second dose. It does take 2 doses to get the best protection. One of the problems with this, one of the things that we've discovered in the Chicago outbreak in May of this year was many of the people who got MPOX actually had been fully vaccinated.
So both doses?
Had both doses.
Okay.
And that was a little surprising. We were hoping that it would be better at completely preventing infection. There was a study published that actually looked at 3 different trials that were done, some trials that were done by looking at medical records and some, in different situations. And the effectiveness of the vaccine is felt to be about 65 to 85%, something like that, effective at preventing infection. But it's not 100%. People who have had the full course of vaccine can still be infected. That probably has to, we don't know exactly why. The speculation, my speculation is it has to do with the fact that there's so much virus on these lesions that if you come in contact with them a lot, you can overwhelm even an immune response. The interesting thing is, and the good news is that most people in the Chicago outbreak, all the people that had been vaccinated did very well. Some of them only had 1 or 2 lesions, 1 or 2 bumps, and they were worried about it enough or whatever and went and sought medical care. Whereas, lots of people would see one thing and it goes away in 2 weeks. They're not going to go see anybody anyway.
Mm-hmm.
But the people who got sick, who got more severe disease, and I think 1 or 2 people were hospitalized, they had never been vaccinated. So it's clear, I think it's safe to say that vaccination prevents the development of severe disease, much like COVID. I think initially when we heard about the COVID vaccine, everyone's like, oh, it's going to prevent me from getting COVID. Now we realize, we're all probably going to get COVID, but vaccinated people are much, much, much less likely to die. And people vaccinated against MPOX are much, much less likely to have severe disease.
And I want to move back really quickly because you started talking about the live virus vaccination versus the one that we're currently using. And so the one that is available to us is not a live virus that is being used in order to build this immune response.
Right. Just to be clear, the word live and viruses is kind of hard because, is a virus alive or not? It's a replication incompetent virus. It can't reproduce itself. Okay.
So if it enters our body, it's not going to be able to start the infection.
Right. And again, it's not a smallpox virus. It's a vaccinia virus, which is in the same family it's in the orthopox family. And so by being exposed to the vaccinia virus, you develop immunity across that whole family. So being vaccinated against MPOX is going to Sorry, I just got someone just rang the doorbell. I think a delivery person, and my dog was all excited. But at any rate, yeah, Amazon taught my dog to bark. He never barked till COVID came along. But So we were talking about the virus. So it's an replication incompetent virus. The ACAM is a attenuated virus, so it's not as severe, but it can cause vaccinia, and a few people can get disseminated vaccinia, not smallpox, but vaccinia, which is the virus that we're using to create immunity against that.
Okay.
It's 2-shot series, about a month apart. Unfortunately, when no one was expecting this outbreak of MPOX, right? No one wasn't really on anybody's radar. Remember, I said if people who are really smart and paying attention to Africa might have been thinking about it, but no one expected what happened last year. And the Jynneos vaccine, we didn't have as much of it as we needed, as we thought we would need. And so initially it was being given subcutaneously, which is under the skin. And then we started getting very nervous that we didn't have enough to immunize everybody we were afraid we needed to immunize. So they switched to intradermal vaccination. Intradermal means actually in the skin. So the skin has a couple layers. And so you have to get that needle in the skin, not underneath the skin. Underneath the skin is easy to do. Everybody can do it. Intradermal is a little bit tougher. It takes longer. But we could get with one vial, we get one subcutaneous dose, but we get 5 intradermal doses. And so the CDC recommended switching from subcutaneous to intradermal dosing, not because one is really better than the other, but to stretch the supply we had. Meanwhile, they were ramping up the supply. We have the problem with the intradermal vaccine, and I'm sure you're going to ask me this question, so I'm getting ahead of you. The intradermal vaccine can cause a bump. It can cause some redness. It can cause some itching, and that can last for months.
Mm-hmm.
And so lots of people were showing me their bump that, how long have you had it? It's been there 6 weeks now. I'm like, well, it's going to be there another 6 weeks. And so people felt, I think that contributed to some reluctance to get the second dose if it had to be intradermal.
Yeah, I just recently finished 2 focus groups on MPOX with trans and non-binary folks in Arizona. And there were a lot of questions that came up, but one of the things that definitely came up was like a fear and concern around scarring or having like a visible mark on the body. And some folks reported that that was their experience of having this visible mark. And so I think those multiple routes, first of all, this is the first time I'm hearing that the shift happened because of we knew that could extend the supply, or at least it's the first time that it's sticking or clicking with me, right? And so it makes sense now why this took place. But from the perspective of the community, it was just like, well, suddenly we've gone from something that doesn't cause a mark to something that does cause a mark.
Right. I think again, the concern initially, I mean, again, it's if you look at the graph of how the rise in infections, I mean, I think we peaked at 700 or 800 infections a day in this country. And so it's going up, 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 and everyone's terrified. And then we're looking at how much vaccine we have. How can we make it? How can we get it to everybody who needs it? And maybe we didn't communicate that clearly enough, but it was simply to try to expand to try to allow more people to be vaccinated, to be protected. Now supply is caught up. There's plenty around. The CDC allows the drug to be given either way. It's patient preference. I recommend, when I give talks to doctors and clinics, I say, just give it subcutaneously. It's a faster injection. Now, the subcutaneous injection, you can still get a little bump. It can be red. It can itch. It can hurt, just like a flu shot or something else. But you don't get that red bump that's there for up to 3 months or 4 months. And I've not heard of anybody getting a permanent scar, but when something's around for 6 months, and certainly, I guess in some ways it's a badge of honor, but in some ways it's unsightly and a little bit stigmatized, a lot stigmatizing perhaps. So, but subcutaneous is available now, and that's certainly what I would, if I was going to be vaccinated today, I would just say, you're going to give me a subcutaneous vaccine, right? And the person would probably say, yep. And then you'd say, great, go ahead.
And I think that that's great language for folks to have, because I don't think that everyone knows what to ask for. Because I remember I got it subcutaneously and intradermally. And so subcutaneously, it was still painful. It was like getting a flu shot. There was like muscle tension and all these other things that it was sore to sleep on and whatnot. But the intradermal one definitely was around for a lot longer.
Right.
And was one of those things where it was, I wouldn't say necessarily a badge of honor, because I know for myself what I'm doing to protect myself, to protect my community, etc. I would say it was more so it's kind of like shining a spotlight. Because there was also the connection of, in order to qualify for the vaccine, you had to be perceived as promiscuous, or there was this perception of you had to be promiscuous. So I think that there are some shifts around that, hopefully, with this increase in supply.
Yeah, absolutely. I think, I guess when I thought it was a badge of honor was people being proactive in taking care of themselves. But yeah, it's a challenge. Yeah, it's a challenge in wording, I guess. But yeah, for sure, I think who should be vaccinated is another question. And, I think, again, it really is a question of, we've tried to be honest with everybody, that it seems to be that the risk is greatest in certain in people doing certain things, and mainly it's men who have sex with men, transgender women who have sex with men. But, people need to make their own decisions around what they do, what their risk tolerance is, all those things factor into that decision. And anybody who wants to be vaccinated now, because I think anybody who wants to be vaccinated should be vaccinated. The other question that comes up is revaccination. Well, the other two questions come. One is revaccination, like if you've had your 2-shot series, when do you need more? And that's an unanswered question at this time. The only other people that were getting this vaccine were people that were working in laboratories with the virus. So, lab workers. And I believe they were getting vaccinated every 2 years, but don't quote me on that because I'm not 100% sure. But so there may be a suggestion that we get vaccinated again in the future. But again, right now, the numbers of new cases we're seeing is really low. And so, we're still not clear how long the protection will last. There is some evidence that people who had smallpox vaccine were protected to some degree even decades later. So unanswered questions there. The other thing that people ask is, if I had a MPOX infection, do I need a vaccination? And currently the answer to that question is no. When I say currently, the answer to the question is no, is because we are learning all the time and things may change down the road. So I think the nice thing is you don't have to walk around thinking about MPOX all the time anymore. Mm-hmm. I think it's just another thing that's out there that you need to be aware of and you need to stay current with. And hopefully more, we'll learn more over time, and we can give better answers to some of these questions that just don't have good answers right now.
And I heard a couple of those like community groups that are often, sorry, there's now an alarm going past my house. I heard some of those community groups that are often discussed as like the priority populations, right, for STI information, for vaccination. So like men who have sex with men, trans women, those generally are the community groups that are shared. And I feel like when we talk about just those groups, other folks in the trans and non-binary umbrella feel like, well, this isn't for me. But what I'm also hearing from you is that this has to become part and parcel of our sexual health, and like part and parcel of, if we're getting other vaccinations for other sexually, like for HPV, if we're talking about other STIs, if we're engaging in sexual activity with folks, then we should consider getting an MPOX vaccination.
Right. I think, just because it's really about what you do, not who you are. Okay. So if you're in a monogamous relationship and your partner's monogamous, none of this really applies, right? But if people, a marker is if you've had an STI in the past year, then that's a signal that you probably are at higher risk for MPOX, as opposed to somebody who doesn't. People who are commercial sex workers, people who go to, large public events or have sex there and things like that. People that are immune compromised, those people need to think harder about getting vaccinated than other people. But it's really, I think it's sort of stigmatizing to point your finger at anybody, but it's also not. We want to be honest and say, this outbreak really seems to be associated. It was really associated. It seemed to start in Europe at these big parties that people were having, and mainly among men having sex with men. So you don't want to deny the truth, but it's not like the virus knows. The virus is just going where it goes, not based on who somebody is, but on what they're doing.
Okay.
Did I say that in a way that makes sense?
Yeah, that makes sense. I think that this is where we get in the weeds around stigma and pathologizing our communities, right? Because we recognize the fact that there might be greater rates of infection in certain communities, but it's not because of who those communities are made up of. It's just because we're seeing more infection present in those communities. And because we exist and live in those communities, we're more likely to come into contact with it. That this is an infection that can impact mammals. But it's like if I think about it of like, well, I have my bedroom and I have my living room. And if I know that there's more dust in the air in my bedroom, then if I enter my bedroom, I'm more likely to come into contact with dust than if I'm in my living room. It doesn't change who I am as a person. It just means that I'm in a community where we're seeing more infection present, but it's not because of the types of sex we're having. It's not because of who we are as people or those pieces. It's just because this is what's present. We're more likely to come into contact with it.
Exactly. Yeah, absolutely. Oh, the other thing I wanted to say about the MPOX. Oh, if you've had one vaccine last August, when do you get your second one? Because it's not a month. Get it now, and that you don't need two. You don't need a 2-shot series now. Just a second one, even though it's been a year. That's the other current guidance. And again, all of this may change down the road. But we're really fortunate in a way that the virus, this viral outbreak, really has dropped off. The numbers are much, much less, but it's not gone. And my own belief is it's not going away ever. It's going to be something that's going to be there. When I talk to medical providers, I say, you got to think about this. If you see a rash, if someone comes in with a rash in their genital region, herpes comes to mind always, because that's been around a long, long, long time. But MPOX needs to come to mind, and we probably need to look for it more than we do. There's been some studies looking at antibodies in unhoused people, and there is some sign that there's basically people not being diagnosed in unhoused communities who've had MPOX. Which, if you think about that, makes sense. I mean, if you're unhoused and you get some bumps on your skin and they go away after a few days or a week or two, you're not going to go see a doctor about those. You have other things to worry about.
Absolutely. Well, and especially in Arizona too, where we might be experiencing heat rash. We might be experiencing all number of things that can cause rash-like symptoms. But the other thing is that it's also generally more difficult to get medical services as someone who's unhoused because of a lack of documentation, not necessarily being insured. Even if we are insured or on access, like unclear if we've been dropped off or not with this large drop-off of Medicaid. Yeah. So I think there's lots of pieces that can definitely
but I think the point, I mean, all those things are absolutely true, and I understand, and it's the story of my life in many ways, but the point being I wanted to make was that there is probably some low level of this virus that's going to persist in, friends of mine were worried that the rats in New York were going to become infected, and then where would we be? That this is the beginning when there was all this, we didn't really know what was going to happen, and we knew that small rodents were the vector in Africa, and it's so I think it's going to be with us, but fortunately it's not as bad as we were afraid initially, and it has gone away. Oh, why it went away? Why did it go away so quickly?
Why did it go away so quickly?
Well, what we think is that basically the community protected itself, that people learned about it. I think the CDC gets blamed a lot, but I think the CDC did a pretty good job with MPOX. I think people had some expertise both from COVID and from HIV. People changed their behavior a little bit. People started to protect each other a little bit. The vaccine came along and a lot of people got vaccinated. And one vaccine does help, clearly. One shot, not as much as 2 shots, but so there was a big response. And I think that response changed the shape of that curve. I mean, in some ways, I wish the whole country had done the same thing with COVID, that our population did with MPOX, and we might have gotten out of COVID a lot quicker. So, people, I mean, again, I've lived through the whole HIV experience, and people have to save themselves at some level, and I think that our community did. To a large degree, and hopefully they're continuing to do that, and there's lessons to be learned, and there's also kudos to be given and accepted.
Yeah, I think it's a lot more, I think there's a lot of nuance to these pieces too, right? So
Sure.
it's, I think that there was a big rollout and a big push for vaccination in many places across Arizona that I mean, we saw long vaccination clinic lines, folks were going and getting vaccinated. And I think to your previous point around folks who are unhoused, I think there are still swaths of our community that have been left out of the conversation or have been left out of the access to care. And this is something that I mean, you and I could also spend a week talking about because it's part of the social determinants of health and all of these pieces that we know there are communities that have systemic barriers present in order to be able to get the health needs that they deserve, and that they need. And I think trans and non-binary people fall under one of those communities that have traditionally been pushed out of medical care. And this is something that's come up in the focus groups. It's come up in pretty much every research article I've ever seen about trans and non-binary people. And so some of the things I'm wondering is that we, because this access has been historically difficult for us to get care, especially for Black, Indigenous, and other trans people of color. What can we say if we are denied the vaccine? What language can we use to advocate for our health?
Yeah, just to go back to your, people being left out. I saw a picture of a line in Harlem, New York, people waiting for MPOX vaccine, and it was all young white guys, and it's
It
in
was
Harlem,
it was
you
kind of the
know.
same though throughout Arizona,
Yeah,
where it was
yeah.
like
So clearly, people of color, all the marginalized people were left out. The MPOX vaccine is not available, except it's a free vaccine. It comes from the government directly, so nobody should be denied it. If someone's denied it, if someone goes someplace and asks for well, someplace that has MPOX vaccine to give, and they get denied, I want to hear about that. The health department wants to hear about that, because frankly, we want to give it to everybody who thinks they need it. We need to vaccinate more, not less. Okay, so there should be no barriers other than the fact that not every doctor's office has it. Again, there is the CDC has a website. They have a vaccine finder. It's not perfect. Each county health department, the way public health is, each state has a different public health system. In Arizona, the counties drive it. So you can talk to your county health department, whatever county you're in, should be able to tell you how to access vaccine, where you can get it. In some counties, in Tucson, in Pima County, El Rio Specialized Associates, the HIV clinic that I worked at for most of my career, they had vaccine on site. Other people, they had it at the health department. They had vaccine days. There's different ways to get it, but everybody should be able to access it, and it's free. And if somebody is denied vaccine, then I personally want to hear about it, and I think the health department wants to hear about it, because that shouldn't be happening.
Yeah, I think it's important that we hear about those because this is something that we are hearing in the trans and non-binary community is either having
Okay.
to like push to get vaccinated because we're perceived as not being part of the priority population because of assumptions about who we are,
Yeah.
or that there are like a number of additional barriers to actually getting it, or we're not being
Right.
asked about it.
Yeah.
So I think that there could be. I also want to hear about this. So if you're listening to this conversation and you're saying like, hey, this is me or my friend has been having issues as well, let us know in the comments so that we can reach out to you and get some more information, or just reach out to me directly, so we can get more information. And we'll include the MPOX like locator, that link that Dr. Carmichael is talking about. We'll include that in the comments below. So if you're thinking to yourself, where can I go? You'll be able to look by your zip code in order to find a place that has MPOX vaccine.
Yeah, I will caution that's not always a perfect tool, because people have to put themselves into it. Clinics have to put themselves in, and then sometimes, if the demand falls off, some clinics stop carrying it and all that. So it's a good place to start, but also your county health department Most of them have it on their website. If you just put MPOX in, they usually have some discussion about where a vaccine is available. And it's, I know around the state, if I've talked to people all around the state that have been giving it, the big problem from a public health perspective is we're not seeing as much demand as we wish we were. There was some data that suggests that you have to have about 30% of the highest risk group highest, if you vaccinate 30% of people at the greatest risk, that will prevent these big outbreaks like we saw last year. In Arizona, we were a little over 30% got one dose, way under 30% have two doses. So Arizona is potentially still at risk for a big outbreak. I don't think we're going to see that, but I'm just saying, looking at what percentage of people are vaccinated. Other states, California, New York, have done much better, and their numbers are high enough that we shouldn't see big outbreaks in those states. But again, we're still learning, and there's going to be, everything I've said today is as true as I can say today, but I'm humbled by I actually, other day I was looking for something that I had written a long time ago, and then I found something else, and oh, look at that, and I started looking at it, and I was quoted as saying some things, and I was like, oh, well, that's wrong now. But it wasn't wrong in 2009, but in 2023 it's wrong, and so things do change, and again, I think, to be completely honest, we need to understand that science progresses and things do change, and what we learn and what we know changes over time, and we only know things because they've already happened.
Yeah. And that actually takes me to my final question for you, which is, where can folks go to learn more about MPOX, the vaccine, that is updated regularly since information is changing?
Yeah. The CDC MPOX website is really good, and they actually have I think there's a section like what's new. Okay, so you can see what the latest is. They have tons of stuff there. It's huge. Sometimes I go there and I'm like, wow, I didn't know about that. They have, posters, and they have lots of things. They have stuff specifically for patients. They have stuff for providers. And my experience, most patients are pretty darn smart and can read the provider stuff and get stuff out of that as well. Each county, the Arizona Department of Health Services has an MPOX page. They have actually a dashboard too, which shows new cases. There have been, I think at this time, I think there's been 4 new cases since June in Arizona. So, we're not seeing, it's not a case every day even. So we're doing pretty well so far, but there is, what I expect to see, just to say that, is I expect we're going to see some clusters all across the country. It's like the Chicago cluster. So it'll be it gets in, somebody gives it to a few people, and then somebody flies to another city and gives it to somebody else. We're going to see these sort of brush fires, if you would. But I don't think we're going to see this huge thing. But I hate to say that because I'll be wrong if I say it.
And by clusters, you mean these like small groups of like
right. So
infection cropping up in communities.
Yeah, and so 3 or 4 people might get it here, and if there's a pool party and somewhere, and there's some sex there, and a couple people transmit it to, one person transmits it to a couple people, then you have a cluster. Gotcha. And then if somebody's there visiting from somewhere else and goes somewhere else, because again, you can transmit before you know you have an infection. Mm-hmm. And that's the problem. If you were sick, if you couldn't transmit it until you were really symptomatic, how does it get transmitted? Because most people don't want to give it to somebody else. Most people, if they feel sick, if they have a bad rash, they're not going to be putting other people at risk, because people don't do that. Yeah. So that's the thing. It's the same thing with COVID. People are most infectious before they start having symptoms. So it's hard to completely shut down all the transmission. So I said the county health department, the CDC has a good website. The Arizona Health Department has a good website. They do have that dashboard. The CDC has a dashboard too for the whole country. Just recently, the other thing is, I should have said earlier, MPOX is now considered an opportunistic infection. So the section of the NIH guidelines about HIV treatment, the section on opportunistic infections, they just added at the end of July a whole section on MPOX. It's not super long, but that's pretty technical stuff. But again, some people are pretty knowledgeable and want to know that. That's brand new, just at the end of July. So those are the places that I would look. I think the CDC is probably they have a really good website. There's a lot of information there, and they're good about updating it and pointing out what's new.
Thank you for those. And for folks who are listening or watching, we'll go ahead and make sure that those are in the show notes as well below. So that way you can just go directly to the link. You don't have to search around to try and find them. I want to thank you so much, Dr. Carmichael, for being here, for sharing your expertise, and for really your commitment to the health of our community, and that like lifetime commitment that you've dedicated to making sure that our communities are healthy and are able to make informed decisions for ourselves of how we're going to engage.
Well, it's absolutely my pleasure to be here. Although I got to say, I feel a little underdressed.
Well, these
So
things happen.
If you have me back, I'll try and do a better job for you. Right.
Well, thank you so much. If you are watching this, if you saw this live, go ahead and put a hashtag live in the chat. Let us know which parts of this you found most interesting. If you're catching this on the replay, put a hashtag replay. If you have questions, put them in the chat. We will be able to respond to those. And as always, thank you for investing in your health. The audience, the folks who are watching this, thank you for investing in your health and well-being and the health of all of us in the trans and non-binary community. Until next time, stay safe.